Welcome to the lesson on Crohn's disease. This is a medium-weighted topic for the exam. Crohn's disease is a chronic, inflammatory bowel disease that mainly affects the GI tract. It is characterized by thickened areas of the gastrointestinal wall with inflammation extending through all layers. Affected areas may occur in any part of the gastrointestinal tract, interspersed with areas of relatively normal tissue. Treatment is largely directed at the induction and maintenance of remission and the relief of symptoms. Active treatment of acute Crohn's disease should be distinguished from preventing relapse. The aims of drug treatment are to reduce symptoms and maintain or improve quality of life, while minimizing toxicity related to drugs over both the short and long term. Drug treatment is first offered as monotherapy. A corticosteroid, either prednisolone or methylprednisolone or intravenous hydrocortisone, is used to induce remission in patients with a first presentation or a single inflammatory exacerbation of Crohn's disease in a 12-month period. In patients with distal ileal, ileocecal or right-sided colonic disease, in whom a conventional corticosteroid is unsuitable or contraindicated, budesonide may be considered. Budesonide is less effective but may cause fewer side effects than other corticosteroids, as systemic exposure is limited. Aminosalicylates such as sulfasalazine and mesalazine are an alternative option in these patients. They are less effective than a corticosteroid or budesonide, but may be preferred because they have fewer side effects. Aminosalicylates and budesonide are not appropriate for severe presentations or exacerbations. Add-on treatment is prescribed if there are 2 or more inflammatory exacerbations in a 12-month period, or the corticosteroid dose cannot be reduced. Azathioprine or mercaptopurine as unlicensed indications can be added to a corticosteroid or budesonide to induce remission. In patients who cannot tolerate azathioprine or mercaptopurine or in whom thiopurine methyltransferase (TPMT) activity is deficient, methotrexate can be added to a corticosteroid. Under specialist supervision, monoclonal antibody therapies, adalimumab and infliximab, are options for the treatment of severe, active Crohn's disease. Adalimumab and infliximab can be used as monotherapy or combined with an immunosuppressant, although there is uncertainty about the comparative effectiveness and long-term side effects of therapy. Maintenance of remission. Patients who choose not to receive maintenance treatment during remission should be made aware of the symptoms that may suggest a relapse, most frequently unintended weight loss, abdominal pain, diarrhea and general ill health. For those who choose not to receive maintenance treatment during remission, a suitable follow-up plan should be agreed upon and information provided on how to access healthcare if a relapse should occur. Azathioprine or mercaptopurine as unlicensed indications can be used as monotherapy to maintain remission when previously used with a corticosteroid to induce remission. They may also be used in patients who have not previously received these drugs, particularly those with adverse prognostic factors such as early age of onset, perianal disease, corticosteroid use at presentation, and severe presentations. Methotrexate can be used to maintain remission only in patients who required methotrexate to induce remission, or who are intolerant of or are not suitable for azathioprine or mercaptopurine for maintenance. Corticosteroids or budesonide should not be used. Maintaining remission following surgery. Azathioprine or mercaptopurine as unlicensed indications can be considered to maintain remission after surgery in patients with adverse prognostic factors such as more than one resection, or previously complicated or debilitating disease, for example abscess, involvement of adjacent structures, fistulating or penetrating disease. Aminosalicylates can also be considered as an option, however budesonide or enteral nutrition should not be used. Other treatments. Loperamide hydrochloride or codeine phosphate can be used to manage diarrhea associated with Crohn's disease in those who do not have colitis. Cholestyramine is licensed for the relief of diarrhea associated with Crohn's disease.